after my professor, Dr. Ilhami. I remember lots of support and mentoring when I was in Egypt, especially during the time that we were starting الزمالة المصرية لأورام الأطفال. شرفت بأن أنا يعني أشتغل معاه وأبقى to learn from him. Before I start the presentation today, I want to share this slide, which is collaborative learning initiative with the Egyptian Pediatric Hematology Summit, and with the team will be, inshallah, conducting series of mini workshops, which we plan to have it for about 3 hours. The time of the day and the day of the week is still not determined yet, because I would like to see what works for everyone, inshallah. But the topics that came to our mind are those topics in front of you, and I would like to highlight one thing here, which is going to be practical case-based. So all these many workshops is going to be case-based, and the idea will be how you approach sort of way of discussing things. So it's going to be interactive, it's going to be case-based, and the learning is going to come from the cases as we discuss it. And because of the many questions about certain topics, I picked up those topics, but again, it's a very flexible thing. Like MRD in ALL and AML seems to be important, recurrent topic, flow cytometry, how to interpret it and how to read it. For the clinicians, not for the hematopathologist, how you approach non-Hodgkin's lymphoma or Hodgkin's disease, how can you approach sepsis and the pediatric hematologic malignancy, and also how you conduct, write, and publish quality improvement work. This is an area that is very dear to my heart, because this is special interest for me, and I'm teaching it at a national level, so I would like to share that with whoever is interested. So this is for further, stay tuned, you will hear more about that, inshallah. Our topic today, not sure if I have control, is going to be addressing a very important issue during treatment. So Professor Ilhami addressed after chemotherapy care, and I'm going to go back to on chemotherapy care, which is the sepsis in pediatric oncology. And I picked the title of the golden hour for early detection and management of sepsis in pediatric oncology, because it's really very important as we will learn about it. The aim of the presentation is going to be to highlight the challenges in the diagnosis of sepsis in pediatrics, is to present the impact of early detection on and sepsis care bundle on sepsis outcome, and finally to discuss the value of standardized pathways and guidelines to ensure consistent outcome. So what is sepsis? When we talk about sepsis, there is a continuum that we have to notice. I'm going to highlight the left side of the screen here. And sepsis, basically, there is interaction between infection on this circle, and then the severe inflammatory response syndrome, or SIRS, and then there's severe shock or refractory shock. Now, you go from one stage to the other without a very clear delineation between the stages. So the patient can be picked up at any of these stages, but it's important to know, just to make things easier for us when we look at the patient. For infection without severe inflammatory response, then it would be like a regular infection. Someone has tonsillitis or has common cold or something like that with some fever, but then the patients start to have temperature and high heart rate out of proportion to the fever, or high respiratory rate, or low oxygen saturation, or very high white count, or very low white count. Then we say the patient has 2 criteria or more of those. This will lead to the SIRS, or the severe inflammatory response syndrome. If you add infection on top of that, that will be sepsis. So if you look at our pediatric oncology, especially when they are neutropenic, you can count more than one criteria to make them severe inflammatory response syndrome. Definitely they will have fever, definitely they will have tachycardia, definitely they have very low count. So they fulfill more than 2 criteria for the SIRS. And on top of that, we suspect infection. So everyone coming with fever neutropenia, by definition, you will see that they fit the sepsis definition, which is really scary. Really, anyone with fever neutropenia is considered septic. Now, if the patient start have some organ dysfunction, then, like for example, high liver enzymes, high creatinine, or decreased urine output, or persistent hypotension, then the patient has severe sepsis. If the patient goes further than that, then he would be in septic shock. So you will see that many of the patients with pediatric oncology, fever neutropenia, they do have sepsis or severe sepsis or septic shock. When you look at this part of the slide on the right side, just focus on the upper part of it, and basically it goes from infection, again, the continuum, to sepsis, to septic shock, to MODS or multi-organ system dysfunction. And up there, it shows the mortality rate that as you go further, the mortality rate goes very high. Now, why is it challenging in diagnosing sepsis in pediatric oncology? It's because of those in pediatric, in general, there is actually difficulty in diagnosing sepsis. So in general, pediatric, there is difficulty in diagnosing sepsis. And when you move to pediatric oncology, it's even harder. I highlighted here in gray so we can focus on that. Is it really hard to diagnose sepsis? Because we feel like sepsis should be easy. We should be able to pick it up very quickly, but the reality is not. And because of that, the WHO in 2017, so this is just a few years ago, they had a resolution to highlight the importance of prevention of sepsis, early recognition of sepsis, and management of sepsis. So once you see that, you know that there is a problem. If they are talking about recognition, then it's not easy. There is no one single test or exam that will tell you this patient in sepsis or not. And when they talk about the management, that you know that the patient in general, they are not getting the proper management for sepsis. Otherwise, why the WHO will get together to come up with a solution for that? Then the American, they have to have their own thing all the time. And now they have what we call the Surviving Sepsis campaign. They came up with a campaign also addressing sepsis, and they are talking about timely recognition. So when they talk about recognition, again, it's repeating the same theme. And timely means that it's very time sensitive, as we know. And then triggers. So not only recognition, but trigger to start what we call sepsis care bundle. So there is more than one catching phrase here that I want you to remember that as we go through this presentation. There was another evaluation that was done in Queensland, Australia, and looking at pediatric patient with sepsis, and they found that the most contributing factor to about 25% of the events of death was lack of sepsis pathway and also delayed or misdiagnosis of sepsis. So the diagnosis of sepsis was delayed or missed completely. And even when it was diagnosed at the right time, there was lack of pathway. What does it mean? What pathway means, we will learn in the next few slides. In France, so we'll talk about the WHO, we're talking about the US, we're talking about Australia, we're talking about France. So it's globally, and it's in the developed countries. So Landry et al., they found that in France there was suboptimal care in 76% of the patients who died from serious pediatric bacterial infection. So what is the epidemiology? That was general in pediatric. What about pediatric oncology? It's even worse, it's even difficult. Why? Because many of the pediatric cancer patients, they may die from non-cancer relapse. They die from complication of treatment. And 50% of the deaths is almost due to sepsis and mortality from sepsis. So this is a huge number. So if the patient gets treated for cancer and then relapse, then we say, you know what, we don't have that much to do with the relapse. We don't control that. But when it comes to sepsis, and you find like 46% of the patient who dies from non-relapse mortality are due to sepsis, then this is a preventable thing. That's why it's very important to pay attention to those patients. And most of the organisms are either bacteria like E. coli, Staph aureus, Pseudomonas, or fungi, which is important here. I would like to highlight the Candida, because usually Candida causes sepsis compared to Aspergillus. Aspergillus, usually it's in the lung. Viruses, because sometimes we take viruses lightly, but something like respiratory syncytial virus or RSV, that many of the kids have that. When it comes to a patient with cancer and getting treatment, then he may die from that, so not to take it lightly. So a study in one of the developing countries, which is Brazil, they looked at sepsis in pediatric oncology patients, and they found 41% mortality for those patients who were transferred to the ICU, and about 20% of the death happened in the first 24 hours. So this is very, very alarming. Number one, almost half of the patients with pediatric oncology admitted to the ICU, they died, and 20% of them died within 24 hours. This means that they probably arrived to the PICU in a later stage rather than an earlier stage to be managed. They also found that positive fluid balance was associated with reduced risk of mortality. What does it mean? When we talk about the resuscitation or about the sepsis bundle, we will see that IV fluid is very critical. And when they say positive balance, 2 to 6%, mean that this patient was giving fluid as part of the resuscitation in order to treat the shock that the patient has. And this is a positive factor that helped decrease the mortality, as we will see. So to summarize all what I said, sepsis is common, sepsis is preventable, and sepsis is an emergency situation. So minutes matter, not hours, minutes matter. And why? Because it's difficult, and also it's challenging to do the right thing in the time frame it's needed. So not only to diagnose it, but to diagnose it, to deliver what is needed to be delivered in a timely manner. And hence it comes the sepsis golden hour. So what is the golden hour? What do I mean by golden hour? It's an hour from the start of diagnosing that the patient is having sepsis to the time that you deliver certain items, and we'll find out those items are 6 items. So it's an hour that starts ticking from the time you diagnose patient with sepsis to the time you deliver the 6 items. This is what they call it, the golden hour in sepsis management. And they found that if you do that in the right way, then the chance of cutting back on the sepsis mortality can reach up to 50%. So the golden hour in sepsis is the first hour in sepsis, that once we recognize the patient has sepsis, then we start implementing some patient stabilization intervention, which include the early recognition, the timely administration of antibiotic, IV fluid, and plus or minus starting pressors if needed. So again, in this golden hour, which is actually 60 minutes, you need to deliver. One, you need to find out that the patient has sepsis. So number one, early recognition. Number two, timely administration of antibiotic and IV fluid resuscitation. Number three, if the patient needs pressor, you start the pressors early enough. Does it really affect the outcome of sepsis? Yes, and this is one of the publications that was published in 2003 showing that each hour delay, each 60 minutes delay in recognizing and managing sepsis will lead to 50% increase in odds of mortality. So the odds of mortality increase by 50%, not the actual mortality itself. The odds of mortality increase by 50%. So time is critical. Time is of an essence in managing sepsis. Once we talk about golden hour, then 60 minutes are not that much. And the WHO and the sepsis campaign came up with guidelines or pathways. Why? Because they don't want you to keep thinking and trying to do different things and not really standardizing it. So in order to standardize things and to make you act quickly without too much time to think about what is next, they came up with an algorithm. And I know the slide probably is not clear, but you can have the slide at any time. But if you look at the left-hand side here, it's starting with 0, which is recognizing the patient diagnosis of sepsis, and then by 5 minutes you already started IV fluid, and of course you have an IV started, you started patient on oxygen. Even if the patient is not hypoxemic, you start the patient on oxygen. By 15 minutes you finish the patient infusion of fluid, whether it's 20 cc per kg or up to 60 milliliter per kg. And now you diagnose if the patient is refractory shock or not. So you can start literally, you give also the antibiotic, you got the blood culture. So literally you can start the pressors if you need to within the hour. So instead of waiting after 1, 2, 3, 4 hours, you can or you should start the pressors, whether epinephrine or norepinephrine, or dopamine sometimes if you will use that within the hour if the patient is not responding to the IV fluid resuscitation. It's very important that we really understand the early and rapid fluid resuscitation. You will keep hearing early, and this is again to emphasize the importance of time, but also not only early, but rapid infusion of IV fluid is critical. So this is just a little graph to show you how important starting fluid. So if you start fluid here on the right, less than 30 minutes and you completed this fluid, there will be only 40% mortality. But if you completed the IV fluid in 60 minutes, which is double the time, then the mortality goes up almost double, up to 73%. So it's really very illustrative here that time is very important. So not only you give fluid, but you give fluid fast. And if you look at the picture here of the IV fluid hanging there, that defeats the purpose. Why? Because if you hang the IV fluid, yes, you're giving fluid and you're giving it early, but it's not fast, it's not rapid. Why? Because you're using gravity here. So they recommend that you give the IV fluid by push. When you push it, like you have a big syringe of 50 cc's or something like that, and you keep pushing it, that will ensure that you're getting the IV fluid very quickly within the 30 minutes or less than 30 minutes, as you can see here in this slide. So number one, you need to give fluid. Number two, need to be fast. You shouldn't be hanging the fluid and leaving to run by gravity. That's not what should be. Well, we said early recognition, correct? So we need to recognize that there is sepsis. So then there will be screening tools, because as I said earlier, there is no single exam or there is no single blood test that will tell you this patient is septic or not. So it would be a group of symptoms, signs, and labs that's going to help you to diagnose that this patient is sepsis. How do we do that? By certain screening tools, and there is many screening tools, and all of them are having abbreviation. If you look at this graph on the right hand side, you will see there is something called PEWS, P-E-W-S, something called NEWS, something called QSOFA, something called 90-30-90, and then there is something called HUES, MUSE, NHS, you name it, as they say, Yani. But most of them are going to be delivering the same thing. So how do I pick the right thing in order to use it as a screening tool? It's actually based on the institution. Whatever the institution decide, they can pick one of those tools, and basically they can tweak it or change it to make it easy for them and start using it. It's very important that you have your own screening tool that you're going to decide. You're not going to invent it, but you look at one that is easy to follow and can serve the purpose, and then standardize it. You shouldn't be using too many tools, only one tool, and everyone is using it, so there will be no confusion. This is very important. Use the simplest, easiest screening tool, and use single tool. Do not use multiple tools, so you will not confuse the people. And what does the tool help you with? It helps you with early recognition of sepsis. Those are examples of some of those tools. PEWS is the most common, which is abbreviation for Pediatric Early Warning Score. And basically it tells you if you have score. So here it gives you score for respiratory system, for cardiovascular, for neurobehavioral. And then there is some extra points. Basically, this is if you have the maximum score is 3 for each one. And then they tell you if you're 0 to 2, then you don't have, you're in the green zone. If you're 3 to 4, you're in the yellow zone. We're not sure. You may go to the green or you may go to the orange. If you're 5, then you're in the orange, and then red, you're in 6, then so on. So that's one example. There is another example here, which seems to be more busy, but it gives you different option here. If you look at that, it's saying that there are some risk factors that will make you even more anxious about the patient, that you don't need that many of finding in order to say this patient has sepsis. So the more likely the patient is at risk for sepsis, for example, malignancy is one of those. So all our patients are having this one. All our patients are going to be getting immune suppressed from chemotherapy. So you have two factors to start with. So your level of suspicion for sepsis is going to be very low to suspect sepsis in those patients. Another way of looking at it, again, highlighting that if the patient has hypotension or 3 of 8 criteria or 2 of the 8 criteria, if he's in high risk category, then you can diagnose sepsis and you can start the sepsis care bundle that we'll talk about. So then we talked about the importance of sepsis, about the prevalence of sepsis, about the time that it's very critical, about how to early recognize sepsis. Okay, now we recognize that the patient has sepsis. What can we do? This is what we call sepsis care bundle. What does bundle mean? Bundle means group of things. As you see, this is the doctor here wearing scrubs, and you see number 6 here on the chest, and we'll talk about what does the 6 means. And then he has oxygen, he has normal saline, some antibiotics, some culture, bottle, oxygen mask, and so on. So basically, there is bundle that need to be done together. If you want to get the best outcome, you need to implement the items, the 6 items in the bundle. Remember that. It's called bundle because you need to do all of them within 1 hour. If you do one of them or 2 or 3 out of 6, the outcome is not going to be the same. And there was a study actually done in New York. They looked at what is the percentage of people implementing the 6 items in the bundle, and guess what? It was only a quarter of the physicians implemented the 6 items in the bundle. So in order to get the best outcome from the bundle, you have to really do the 6 items within the time frame, which is the 1 hour. So that's number 1. So bundle is a set of evidence-based intervention that has series of intervention that is very critical to be done in the time frame. And the benefit of that is it standardizes the care. It improves the adherence to the standard of care. For example, if you have that written and it's in front of you and the team knows that we're going to do 6 items, this is how the care bundle is. You have language that everyone is aware of it. And yes, if we call this is sepsis, then I know that I need to deliver the 6 items in an hour. Easy. Everyone's going to do that. If you do that, then you're going to help each other, and that will lead to decreasing mortality by 50%. Different way of looking at it. We said it's bundle. People will call it algorithm. It's okay. It's not going to make that much difference. Let's look at here the 1, 2, 3, 4, 5, 6, as I just mentioned to you. Number 1, if you look up above number 1, you will see the time here. It's about 5 minutes to recognize that the patient has sepsis. You use the sepsis screening tool. After that, once you decide the patient had sepsis, you start having IV or intraosseous. Number 2, once you put an IV, you collect blood culture. And number 4, I jumped number 3, you're going to collect lactate, because lactate is very highly linked to the outcome in sepsis. And you start empiric broad spectrum antibiotic. You're going to give IV fluid, and you're going to start vasoactive or vasopressor. So again, those are the 6 items in the bundle that you need to combine if you want to get the outcome. And look at this circle here. It's saying that continuous monitoring or reassessment is very critical. So again, once you diagnose the patient in sepsis or septic shock, then you need to initiate the bundle, the 6 items, and you need to continue to monitor the patient. The British looked at it in a different way, and they also came with the 6th bundle, and it's the same thing here. All the difference here, it's like a scorecard. You can have it so you can check the item. It doesn't matter. Whatever you use, whatever is good for your team and your hospital, use it. So how can we implement this? So it's great, it seems to work. How can we implement it? Certain tips for how to implement it. Number 1, you need multidisciplinary approach. You really need the parents. The parents, what are the parents are going to do here? They found that the parents are the early warning sign. The parents will say, oh, my child is different this time. He doesn't look right. He's not fully awake as he should be. He's looking sicker than last time. So listening to the parents is very critical. I always tell the resident and the fellows, listen to the parents. They know their child the best. You don't know their child. So when they say he's not right or she's not right, then take their words. The nurses, because the nurses are going to be taking care of the patient in the ward or in the emergency room before they see you, the oncologist and the pharmacist, of course. In order to help them to internalize or to learn about sepsis, you need to do some training. You need to implement the sepsis screening tool that you decided on it with your team, decide which one you're going to use and make sure they are good at it. Educate the healthcare provider about the 6 items in the bundle care, and have a rapid response team, meaning that once you hear that there is sepsis, you really need to go to the place where the patient is and for the nurse to be there, for the pharmacist to be there, and for the oncologist, the most senior person to be there. Why? To give the best care for this patient as much as it can be. What is the impact of doing this sepsis bundle? That will reduce mortality, as we just mentioned, by 50%. It will help to standardize the care. If you go to الزقازيق أو عين شمس أو القاهرة أو أي حتة، أنت عارف إن أنت لو عندك سبسس هتستعمل ال6 ايتم بتوع البندل. خلاص you're standardizing. لو جه النايب اللي لسه متعين النهارده أو الموست سينيور نايب هيستعمل نفس الحاجة. فstandardizing the care make error much less likely. Improve adherence. Why? Because now it's ingrained in our brain. We do it all the time. So we are, you know, we don't need to think about it, as they call it, no-brainer. It's like, you know what, I'm just going to do it. So to conclude, early recognition of sepsis at multi-level, including parents, nurses, physician, utilizing the golden hour and using the sepsis care bundle approach are critical component to significantly improve sepsis outcomes. So again, I want you to remember this: early recognition of sepsis at multi-level, which include the parents, nurses, and physician, utilize the golden hour and use the sepsis care bundle. What does lead to do? Adopting those 3 principles lead to saving lives among those patients who are very vulnerable. Those are some references. I grouped it here for the future, and thank you very much.
Thank you very much, Dr. Ashraf, for this elegant, comprehensive presentation. I would like to ask you one question only. You say that we should start with 60 ml per kg IV fluid soon in the first hour or even in the first 15 minutes. Sometimes we give the 60 ml per kg, but the child is still oliguric or even anuric. Shall I repeat it again, or just give the pressors without repeating the IV fluid boluses and put the patient on a zero balance or fluid chart balance for fear of pulmonary edema or volume overload or something like that?
Yeah, thank you. This is very important thing. So let me clarify that. You do 10 or 20 cc per kg each time. So we don't give the 60 milliliter. The cumulative is 60 milliliter. So we do it 3 times. And why do they say 60? And actually, you can give up to 200 milliliter. But once you exceed 60 and the patient is not responding, then you know that this patient for sure needs pressors and for sure needs to be in the ICU. So by that time, you should have notified the ICU. Now, to prevent the fluid overload, we do 2 things. Number 1,